Today we will learn about this pachychoroid disease spectrum, and this is going to be the second lecture in this series to learn this disease. The initial lecture, the link of which I will provide in the description, will be having the details about the basic terminology which is used to understand this disease. Pachychoroid disease is a recently discovered disease, and why it is so, we will be explaining that before embarking on to understanding the disease. Now, choroid is a tissue which cannot be easily visualized by normal tools because it lies underneath the opaque retinal pigment epithelium. So choroid visibility is very limited, and the only tool which has been helping us was indocyanine green angiography. But that being an invasive procedure plus issues related to the dye itself has limited the procedure for very specific indications. So we'll just ponder upon the ICG findings in few relevant diseases which are now considered part of the pachychoroid disease spectrum. So when ICG is being done in these patients of central serous retinopathy, it was seen that as seen on an angiography, fluorescein angiography, there was usually a hot spot or a leakage point in form of a dot blot or a smokestack pattern, which was supposed to be a classical one. When this was compared, this angiography is compared to ICG angiography, in this patient we can see that there's a leakage at the posterior pole corresponding to this area where you have the central serous retinopathy and a leakage at the retinal pigment epithelial levels. So similarly, polypoidal choroidal vasculopathy or PCV also showed that when we have the diseases of the retina like CSR and PCV, the ICG has demonstrated presence of leaking in the choroidal blood vessels. So this is one patient in which there is a PCV, and we can see that this is a ICG angiography, and it shows a serosanguinous cavity partially filled with blood, and partially there's a serous detachment of retina, and there's a polyp here plus some leakage and abnormal vascular network at the posterior pole in the choroid. The late phase shows hyperfluorescence in the late phase. This serohemorrhagic PED becomes hyperfluorescent in the late phase. Now these are the situations where it was identified that the choroid in these diseases is not normal, but this information was limited because of the invasive nature of the ICG angiography. Now with the advent of enhanced depth optical coherence tomography, that is EDI OCT, and swept source optical coherence tomography, that is SSOCT, and OCT angiography, now there is a better understanding of choroidal disease, and that too with help of non-invasive techniques where no dye has been injected. Now this is a patient with chronic central serous chorioretinopathy and subretinal fibrosis due to secondary choroidal neovascularization, which is evident on the red free fundus image. We can see the scar here, and when fluorescein angiography is done, there is a widespread retinal pigment epithelial changes around the fibrosis. So this is the fibrotic area, and we can see retinal pigment epithelial changes so that the background fluorescence is missing. And middle phase indocyanine green angiography suggests polypoidal like neovascular lesions. We can see these lesions here, and we can also appreciate that the choroidal blood vessels are leaking profusely, so there is loss of contrast of the blood vessels. The blood vessels cannot be defined separately because this is a mid to late phase of ICG angiography. Now, when we have swept source optical tomography available, now this is a end-phase swept source tomography view at the level of the retinal pigment epithelium, which reveals the neovascular network extending from the fibrosis. So we can see this neovascular network, and this is the fibrotic area, and this is seen without use of any dye. 25 micron below the RP reveals a distinct focal choroidal dilatation at the level of choriocapillaries. So this is the level of choriocapillaries, and we can see this abnormal network with dilated blood vessels. When it is seen deeper down at 200 micron below the RP level, we can see the choroidal dilatation in large blood vessels as well. This is supposed to be the Holler's layer. And now we can appreciate in comparison that how efficiently these new tools are providing us information about the choroid in these diseases. So equipped with these tools, now it is possible to define the choroid status in the diseases of retina, and that is how the pachychoroid disease has been in focus now, and we are able to understand the role of choroid and the pachychoroid as a role played by in the diseases like CSR, PCV, and other diseases which will be coming and encountering next. Now, first, let us consider the anatomy of the choroid, which is important here. Overall, the choroid is a multi-layered structure with ambiguous division into 4 layers, and 4 layers are choriocapillaries, Sattler's layers, Holler's layers, and the suprachoroidal space. Overall, the choroidal thickness ranges from 150 to 450 micron, and this huge range is not only variable in individuals, but in an individual also, in a long term and short term, it can vary. Here is a corresponding diagram of OCT with source imaging, and we can have a schematic diagram here. This represents the retinal pigment epithelium, and below that we have the choriocapillaries, and then we have the Sattler's layers and Holler's layers, and these are all arranged in a manner from inside out. Now, after the brief introduction to the background knowledge and evolution of knowledge, we come to the actual topic, that is pachychoroid disease. That pachy means thick, and pachychoroid is a relatively novel concept which describes these issues associated in the choroid. First is the attenuation of choriocapillaries. So normally the choriocapillaries, which can be seen in this part which is away from the fovea, are absent in this particular area. Same is happening here. Second issue is dilated and thick choroid. So overall choroidal thickness has increased. We can see that in this area, subfoveal area, the choroid is relatively thicker when compared to the other areas. And there is progressive retinal pigment epithelial dysfunction, which results into various lesions. And there is evidence of neovascularization, which can be type 1 or type 2. Type 1 is which is beneath the RP, and type 2 which is above the RP. Coming to the diseases which are included in the pachychoroid spectrum disease. First is the central serous chorioretinopathy, and we will come further into the detail into this topic when we talk later. And here are a few images which show central serous retinopathy. This is a serous detachment of the overlying neurosensory retina. This is the retinal pigment epithelium, and we can appreciate the choroid is grossly thickened in all these patients. Then comes the pachychoroid pigment epitheliopathy. Here we have subtle changes in the retinal pigment epithelium, and this is supposed to be the initiating disease which starts when you have pachychoroid. And here we can appreciate the two eyes of the same patient, the choroid is grossly thickened and there is pigmentary changes. This is autofluorescence image, and we can see some amount of autofluorescence here. Then we have Pachychoroid Neo-Vasculopathy, where we have type 1 or type 2 choroidal neovascularization, which can be seen here on OCT angiography at the level of retina, and this is at the level of choriocapillaries. We can see this particular area where we have network of blood vessels which represents neovascularization, and here we see some amount of subretinal fluid and choroid which is thickened. So this is also known as PNV, Pachychoroid Neo-Vasculopathy. Then we have Polypoidal choroidal vasculopathy, where we have exudative choroidal neovascularization. Color photography shows pigmentary changes in the retinal pigment epithelium plus presence of these retinal pigment epithelial detachments, which are basically type 1 neovascularization, CNVM. Then we have peripapillary pachychoroid syndromes, where we have presence of similar disease, but instead of predominantly involving macular area, there's involvement of the retina which is close to the optic disc. So here we have OCT, swept source OCT, which shows us that the portion of the retina in the macular area is fairly normal, but we can see the choroid which is thickened close to the disc. Normally the choroidal thickness is maximum at the macular area normally, but here we can see it is more thick near the disc, and there's some serous detachment of the retina, and here we have intraretinal cystic fluid in the other eye. The last component of this pachychoroid spectrum disease is the focal choroidal excavation, and this is supposed to be a healed stage of any one of these predeceasing diseases, and there is a pit forming in the choroid with overlying retinal pigment epithelium conforming to the pit, and the overlying retina, neurosensory retina, either there's a gap or it is conformed or it is also deformed. So this is supposed to be the healed stage of any of the above diseases of this spectrum. So these 6 diseases are presently considered part of the pachychoroid spectrum diseases. Now, when we are talking about pachychoroid spectrum diseases, there are common denominators. There are issues which are common to all these diseases, and let us just enumerate all of them one by one. So first is the focal or diffuse increase in the choroidal thickness. Subfoveal choroidal thickness in normal subjects has been reported to be between 191 to 350 micron. But this choroidal thickness varies largely because of age, axial length, refractive error, blood pressure, as well as time of the day. But in these patients, it's very difficult to pinpoint the abnormal thickness, but it is well obvious that just like this source OCT, we can see the thickness is increased when compared to the other areas. And this disproportionate increase in the thickness along with the retinal pigment epithelial changes is one of the hallmarks of pachychoroid spectrum disease. Focal or diffuse. Another feature which is common in PCSD is dilatation of choroidal vessels in the Haller's layer, which is having the largest caliber choroidal blood vessels. And here in this ICG in a normal person, the Haller's and Sattler layer blood vessels have been pointed out. And when we look at a patient with pachychoroid disease, we see this large dilated blood vessel in the subfoveal area. And this is a ICG image which shows blood vessels which are not tapering at the posterior pole and they are abnormally dilated. There's slight leakage. Another denominator is focal or diffuse attenuation of the choriocapillaries and intermediate caliber blood vessels. So here we can see the choroid is not only thick, but the medial caliber blood vessels in the choriocapillaries are absent, or there's only dilated blood vessels. All these changes are supposed to be because of ischemia. So here we see an ICG image of a normal individual where we can define each individual blood vessels as seen on ICG. And when compared to a patient with pachychoroid disease, we see dilated blood vessels and there is haze at the level of the choroid and diffuse leakage indicated by loss of contrast of individual blood vessels, which can be seen in this image. So in a pachychoroid disease, there is inflammation and supposedly some kind of ischemia. There's a question mark placed because this is something which we don't know yet. But this is sure that these blood vessels in the pachychoroid disease are not only dilated, but they also leak on ICG, indicating some amount of ischemia and inflammation. So these four are common denominator in a pachychoroid disease. And then let us move forward and look at the diseases separately. Now, the first component of this disease is CSR, which is fairly common, and we have been seeing this disease for quite some time. And we all had patients in whom there was either a classical smokestack pattern of leakage or ink blot or diffuse leakage with a serous detachment of neurosensory retina. And this disease has a unilateral occurrence and is commonly seen in young males, and there's a relative scotoma with some amount of metamorphopsia because of the distortion of the overlying retina and a hyperopic shift in the patient's refraction. It has a known association with systemic steroids and sympathomimetic use. When we look at the choroid in these patients, we'll find this is one patient in whom both the eyes have been imaged, and we can see that there's a CSR cavity here. There's some pigment epithelial changes as well, some amount of PED here, and we can also appreciate that the choroid is much thicker when compared to the other eye. And this has been delineated by the machine auto programs, which have delineated the boundaries of the choroid here, and we can compare and see that the choroid is thickened. And when we look at the ICG in these patients, we can also see some amount of leakage from these blood vessels, which I had discussed in the previous slide. Next disease is the Pachychoroid pigment epitheliopathy, or also known as PPE. It was first introduced by Warrow and colleagues, and it is characterized by RP changes at the posterior pole over regions of choroidal thickness, which can be seen on a swept source or an enhanced depth imaging OCT. And there is minimal of visual disturbance, and usually it may be an accidental finding, and the patients are younger when compared to ARMD, which can also mimic such a situation where you have retinal pigment epithelial changes, and there are no CSR and no drusense. And this is one such patient in which we can see some pigmentary changes here. And when we look at the swept source OCT, we can see that the choroid is grossly thickened here. There's loss of medium-sized blood vessels, and there's dilated blood vessel in the Howler's layer. Few of these patients may actually proceed to type 1 choroidal neovascularization, which may be a finding in PCV. So these patients may actually progress to other diseases in the same spectrum of the pachychoroid disease. Pachychoroid Neo-Vasculopathy. Here, apart from the choroid being thickened, we have now a neovascularization occurring, which would be subretinal space, and again the associated finding that there's a thickening of the choroid and there's absent or minimal soft drusen, and the age is young. And this is important to differentiate these patients from age-related macular degenerations. Now here we have a patient in whom we can appreciate these changes, that there is a exudative PED here. On a autofluorescence, we see some pigmentary disturbances, On angiography, we see some leakage at the posterior pole, which is speckled. On a ICG, we can see a CNVM, and on OCT angiography, we can see the CNVM at the level of choriocapillaries. On optical coherence tomography section, we can see the choroid, which is thickened. Now, it's important here just to mention it at an appropriate place to compare these three diseases, that is CSR with polypoidal choroidal vasculopathy and ARMD. It will be useful for us if we can differentiate between them now. So in CSR we have no drusense, and on FFA we see some leakage, and on ICG we can see choroidal vascular hyperpermeability. As seen here, the blood vessels are all hazy because of the leakage and loss of contrast. And on OCT we can see a thick choroid with large blood vessels, medium-sized blood vessels are gone. There's a CSR cavity, and there's a small PED here. This is CSR. When it comes to PCV, which we'll see in next slides, if we compare this to CSR, we find there are a lot of similarities here. On a color fundus photograph, there's a serous detachment. On angiography, there's a leak. On ICG, there's a branching network vasculopathy, and we have a CSR with a high peaked or a thumb-like PED together with double layer sign indicating separation between the retinal pigment epithelium and Brooks membrane, and we have a thick choroid. So this, if we can look at these two pictures, you will find that maybe that PCV is actually an extension of or further advancement of CSR in few of the patients and presenting as a separate disease entity in a continuous spectrum when compared to CSR. On the other hand, when we look at ARMD, we'll find drusense and RP changes. On FFA, there will be leakage and window defects because of loss of RP. On CNVM, on ICG, we can see CNVM and leakage. And most importantly, we'll see not only retinal elements, but we'll find that the choroid is thin and atrophic, and presence of drusen and CNVM. So this slide sums up the difference and similarity between the CSR, PCV and ARMD, which may be important for us to understand because frequently these patients have been labeled earlier as ARMD patients. Coming to polypoidal choroidal vasculopathy, also known as PCV. This was first described by Yanezi et al. In 1990, and these lesions, orange nodular lesions as terminology uses polyp, so it may confer a meaning that these are solid lesions, but in fact they are actually aneurysmal dilatation of blood vessels. So now the term proposed is PCV-80, aneurysmal type 1. So it is in fact a type 1 choroidal neovascularization where we have choroidal neovascularization occurring in the subretinal plane, sub-RP plane. Patients have thick choroid. This is one such patient. We can see a hemorrhagic and a patient with whom we have a central hemorrhage and suspecting a membrane CNVM here. There are hard exudates indicating some kind of chronicity in the disease, and there are pigmentary changes. When we look at the OCT, we'll find that there are pachy blood vessels, that is thick blood vessels in this area compared to the other areas which are normal. We have tall peaked fibrovascular PED. This is one of the hallmark of PCV. And there's a double layer sign, separation between the retinal pigment epithelium and the underlying Brooks membrane. When we look at angiography, we see window defect in the RP. These are the window defects in the retinal pigment epithelium. There is stippled hyperfluorescence in the area of PED. On ICG, we see polyps which form the hot spot and a stippled hyperfluorescence in the area of branching vascular network, which is seen here. Next in this family is a peripapillary pachychoroid disease, in which overall the situation is nearly same, thus the location has changed from beneath the retinal foveal area, it has shifted to the area close to the optic disc. So it has the maximum choroidal thickness which occurs close to the optic nerve rather than subfoveally, and these patients typically present with nasal, macular, intraretinal and or SRF and occasional optic nerve edema. So here we can see there is intraretinal fluid and we have subretinal fluid as well, and other lesions which are localized close to the optic disc are pigment epitheliopathy, serous PED and gravitating autofluorescence tracts can occur. So this is another patient in whom we have autofluorescence image, and these are the OCT images which show us the pachychoroid blood vessels in closer to proximity to the optic nerve, and we have intraretinal fluid and subretinal fluid, and this is part of the peripapillary pachychoroid disease. Focal choroidal excavation, also known as FCE. These are localized area of choroidal excavation, and usually they have to be differentiated from other areas of scleral ectasia or posterior cephaloma, and they don't have any disease which can contribute to thinning of the choroid. There are no significant symptoms or sign. It is diagnosed on OCT and associated with pachychoroid conditions CSR, PNV or PCV, and they are commonly seen in patients contralateral eye which is having these particular diseases. So the eye which has either labeled as normal may have an increased incidence of FCE or focal choroidal excavation. There are two types, conforming type and non-conforming type. This is a conforming type where the retinal tissue is conforming to the pit or the depression, and non-conforming type where the retinal pigment epithelium and the neurosensory retina is separated and there is a presence of some amount of SRF. So this slide sums up all those diseases which we have just discussed. So central serous chorioretinopathy, pachychoroid pigment epitheliopathy, pachychoroid Neo-Vasculopathy, polypoidal choroidal vasculopathy, peripapillary pachychoroid syndrome, and focal choroidal excavation are supposedly various stages of the same disease spectrum. Now, when to suspect pachychoroid disease? Now, these are few. This is one schematic diagram which indicates that when we should be suspecting pachychoroid disease. Now, pachychoroid disease is to be suspected in patients who are younger relatively, who don't have drusen's or any other inflammatory retinal diseases, and we find there are PEDs with subretinal hemorrhages and exudates, or we have choroidal vascular complex with polyps. Polyps are basically PED with choroidal neovascularization type 1, or we have neurosensory retina detachment along with which can be hemorrhagic, and there may be exudates. So these are the conditions which are very similar to patients who present to us with ARMD, but as I have repeatedly mentioned, we should look at the age of the patient, presence or absence of the drusen, and look at the OCT images in swept source or enhanced depth imaging OCTs, which can delineate the increased thickness of the choroid, loss of choriocapillaries, and dilatation of larger choroid blood vessels. Now, this is a hypothesis which has been proposed to understand the process, how pachychoroid disease advances, and these various diseases which we have just mentioned are just halts or in between stages when diseases transits from one stage to the other. Now, it is supposed that ischemia, capillary occlusion or VEGF secretion is the key trigger factor which can cause a hyperpermeable thick choroid where the blood vessels are leaking, and if the retinal pigment epithelium is able to overcome the fluid load, then this results into a pachychoroid pigment epitheliopathy. In case this is not so, that the RP is unable to overcome fluid overload, then we start having leak in the subretinal space and we end up into having a CSR. These two conditions can further progress and cause a micro rip in retinal pigment epithelium, and we have Pachychoroid Neo-Vasculopathy, where you have neovascularization above the retinal pigment epithelium, and we can have polyp formation in the subretinal space, which forms the PCV. And all these diseases, when they heal, they result into a FCE or focal choroidal excavation. Now, this is supposedly a hypothesis which may stand true with time, or which may have further modifications depending upon what we next find in this newly discovered disease. Thank you.